time. So we will start with Dr. Meena Lakshmipathy, who will talk about um, what we emerging infections. Why is it an area of concern? No? Take 15 minutes each. And what we'll do is, since we are overrunning.
Good morning, everybody. Sorry for the late start. So the topic given to me by Dr. Anita is emerging infections. And believe me, I've never struggled as much, and I hope to make sense in the end of 15 minutes. The objectives of my talk is to define what is emerging infections, the current trends, what are the organisms, what are the outcomes in special situations such as cross-linking in lamellar keratoplasty, whether there are outbreaks after seasonal environmental changes, and whether contact lenses and shifts in the operating room protocols can affect, and whether there is a role of diagnostics in identifying newer emerging infections, and whether COVID has played any new role. So the definition of an emerging infection is that an infectious disease which has newly appeared or in a population, or that which has previously gone and had existed but now is increasing in incidence and geographical range. All this is because of change in the environment and antimicrobial resistance. In the current scenario, we have a higher incidence of infectious keratitis in the lower socioeconomic age groups and in a very productive age groups. In developing countries, it is in the range of 113 to in the range of 799 in the developed countries per 1 lakh population. It is sad because only 1 in 70 of these infectious keratitis people get corneal transplant when they need it. The Asia Cornea Society produced the retrospective data of 6,000 patients, and they compared what was the trends in the infections in the Southeast Asian. So here we find that there is predominance of fungal keratitis, that is the filamentous fungi, and next is the Pseudomonas, which is the gram-negative bacteria. In the India, the maximum number of cases are fungal keratitis, and these were also close to 50% of the Essex study. When we looked at the SN data for what was the types of bacterial flora in 2014 to 15 versus 2019 to 20, we found that there was an increase in the incidence of gram-positive bacterial keratitis in isolates versus the gram-negative, which were getting lower in incidence. In the trend analysis, you always have to study if there is an increase in the incidence of one bacterial flora, you also see the incidence of resistance to the topical antibiotics, which are commonly fluoroquinolones. So this trend analysis of 8-year data showed that there was increasing incidence of moxifloxacin resistant to Pseudomonas, and the most common bacteria was a gram-positive. So before we go into the isolates subjected by the bacterial keratitis, we need to know that there's a change in the bacterial flora of the conjunctiva which could affect the incidence of keratitis. So Grabowski produced a nice data where he saw that the health of the individual can also produce changes in the bacterial flora, and also there were very good FDA approved studies like the TRUST and the ARMOR studies which brought out what was the incidence of fluoroquinolone, which was increasing in its resistance especially to gadifloxin, moxifloxacin, which are the 4th generation, versus the ciprofloxacin, which are highly resistant to the MRSA group of organisms. So what's new? So you will have many review articles which will give you an idea, or you could look up the data yourself and come to a conclusion. What we will see over the past 2 decades is gram-positive organisms, which are the commensals or the streptococcus pneumoniae being the most common, and now increasing Pseudomonas is being reported. So when I said the commensals are being increased, it's because of the increasing incidence of ocular surface disease and use of a lot of antimicrobial agents. So the Corynebacterium diphtherias, which are the commensals, have known to be increasing in the last few decades, but surprisingly they did not have any difference if they were mixed with other organisms. The Corynebacterium amiculatum is the most common species, and the fluoroquinolone resistance was nearly 40%. So when we look at those commensals which were producing innocuous infections, Serratia is known to be increasing in incidence in the Western population. It's a gram-negative. So on the slide, it looks typical of Pseudomonas, but it is known to increase in India with a history of previous ocular surface surgery or ocular surface disease. Also, you need to look into the literature whether any other ocular conditions can increase its incidence to help you treat the patient. Acid-fast bacteria such as nocardia, which is weakly acid-fast bacteria, has been existing in India for last 2-3 decades. But the SCUT trial proved that it has suddenly increased to 10% in the population near Madurai. So you have to identify the clinical presentations of this typical infection, which is classically described as wreath-shaped. So this will help you identify and tell the microbiologist. Trend analysis of this rare infection also has shown that it is relatively sensitive to amikacin. You also have to differentiate from the other acid-fast bacteria, which is the atypical mycobacteria, but it is 20% acid-fast, and it has a potential to cause cluster infection and responds only to combination therapy. Versus the parasitic infection, the rare infection, Acanthamoeba, you will see that in Indian population versus the Western population differs in that in India, it is not a contact lens associated, it is a non-contact lens associated. It's post-traumatic and it has variable presentations. Garg et al. Have given a very nice review article where they've said that all patients have to be subjected to Acanthamoeba when it's a chronic keratitis, when you suspected HSV and it's not responding, or when you suspected bacterial or fungal and it's not responding to these infections. It can coexist with Staphylococcus infections commonly, and do not be surprised. When we looked at our trends in the fungal flora, we found that Demotaceous fungal flora were existing 5 years in more, and now it has become less. But versus in the newer literature, you will see that Demotaceous fungi has become increasing in the incidence. And a lot of other filamentous fungi with weird names are now being reported. So you will have to go through the literature and see what is the commonest fungal filamentous fungi that is in your region and come to know about it. So Agarwal et al. Have produced an article where they describe that whenever you see a fungal keratitis not responding to proper treatment, go in and look in what are the risk factors. You have to identify what is the particular species of the organism, get the culture and do the PCR, and this will also help if you want to do an antifungal susceptibility test to identify how virulent this organism can be. So some of these filaments do not produce spores, so you cannot identify on the culture media. So they form something known as non-sporulating mold. So you have to subject these to PCR DNA sequencing. These are all the species that we can identify by PCR DNA sequencing, and the non-sporulating mold do not differ from that of filamentous fungi, and they look very much like feathery hyphate margins, just like fungal filaments. So we have an oomycete, which is the Pythium keratitis, and it has come into incidence with increasing water pollution, especially rain and muddy water contamination. But we also have some papers stating that it can also be produced in white-collared professionals and not necessarily but traumatic. You have to suspect Pythium when there is non-response to fungal keratitis regimen, especially 5.5% of the non-sporulating molds of suspected fungal keratitis can be Pythium. So this is how it presents. It presents with tentacles radiating dot-like infiltrates in the mid-stroma, and it can form radial keratoneuritis. In the scenario of post-cross-linking, the commensals dominate in causing the post-CXL infections, the most common risk factor being the epithelial debridement, BCL placement, and steroid application. And the most common organism is the Staphylococcus. But beware, you can also get fungal keratitis, like I saw in this patient. When we cultured, it was Aspergillus flavus. Post-lamellar infectious keratitis, dot-like infiltrates between the lamellar DSEC or DMEC button and the host donor can have Candida keratitis. So this is an increasing incidence of Candida keratitis forming an interface keratitis in post-lamellar keratitis. But beware, this is a post-surgical condition. Like I saw in this patient, this was an MRSA keratitis which was resistant to fluoroquinolones. We have seasonal outbreaks in India because we have the monsoon season, and particularly we have studied the microsporidial outbreaks right from 2011, and it has been proven beyond doubt that water contamination during monsoon can cause outbreaks of keratoconjunctivitis with punctate epithelial erosions. And this can also cause stromal keratitis, but not like in an epidemic form, which is a slower growing infection. So the contamination in the operating room, we have had reports of Burkholderia capacia, which is a gram-negative infection, which caused contamination of the anesthetic drops and causing an outbreak of infection because of poor surveillance. Contact lens related is very important because now you have increased use of software professionals buying these contact lenses online, and the risk of contamination and poor hand hygiene can increase the incidence of contact lens keratitis. The most common organism in India and abroad is Pseudomonas, but it's in Serratia marcescens, which is one of the gram-negative infections, is also known to cause contact lens keratitis. So these are some of the pictures of how the contact lens keratitis appears. So Stenotrophomonas is one of the gram-negative infection which can form biofilm, and now it is being reported as forming one of the causes of contact lens keratitis. So after the cross-linking, we have told that there is there are most common causes, Staphylococcus epidermidis, I've already told that. So coming to investigations, the gold standard is culture. And once the culture is not identifiable, we have to subject the sample to PCR and confocal microscopy. The advantage of PCR, it is very, you need very small material, it is very fast, but it has a very high sensitive, but can give you a lot of false positive. That is, it cannot identify dead and viable tissues. So this is how it is done. You subject it to sequencer and blast analysis. So now we have come to the newer generation sequencing, in which a smaller fragment of the DNA can be sequenced in a matter of hours, but you need to have a culture specimen for this. Again, it takes 4 to 5 days, and robust data exists only for Acanthamoeba and bacteria as of now. COVID related, we see that there is a change in the ocular flora, more towards the commensals. The coagulate negative Staphylococcus has increased in COVID patients who are affected by COVID. And those patients who have survived COVID have shown that they have a unique way of not getting the commensal related infections, but rather they've got the rarer infections, the microsporidial keratoconjunctivitis. This study showed that the patients who recovered from COVID in 3 months develop more of microsporidial keratoconjunctivitis. So the take-home points are, you need to know the typical features of each of keratitis as much as you can, so broaden your knowledge. Newer organisms need newer modalities of investigations. You need to look out for the commensals coming out as an outbreak in your area. Do a good literature search and find out what are the resistant, how much resistant it can be to the routinely used antibiotics or antifungals. And by doing this, you will reduce the antimicrobial resistance.